All right, everybody, welcome. So today we're going to do a really fast, really practical, high-yield guide to CNS infections. Look, you can read the textbook for all the esoteric stuff. This is the playbook you're going to need when you're on call. So let's just dive right in.
Okay, so picture this, right? It's 3 in the morning. You're completely gassed, running on fumes, and this really confusing head CT from the NICU pops up. It's just subtle, kind of weird looking. And of course, the neonatologist is already on the phone. Hey, what do you see? You know that feeling, that pit in your stomach? Well, we're going to get rid of that. We're going to replace that with some real confidence. So here's the secret, and it's a big one. The way you crack these tough cases, it's not by memorizing these huge, endless lists of bugs and all their weird manifestations. No way. It's all about pattern recognition. Seriously, once you learn to see the classic patterns, your differential just shrinks right down. And a lot of the time, the diagnosis just kind of pops out at you. Okay, so let's jump into our first pattern. Let's talk about calcifications in a newborn. The second you see this on a scan, your brain should just fire off one word: torch. Right? These are the big ones, the infections that really do the most damage, especially in those first couple of trimesters.
Now, here's where it gets really interesting. Not all calcifications are created equal. Far from it. The location, that is everything. So cytomegalovirus, CMV, is the most common of the torch infections, and it has a favorite place to go, the germinal matrix. And what does that give you? It gives you those classic periventricular calcifications, lining the ventricles. But Toxo? Totally different story. Toxoplasmosis is much more random, and it really loves to hit the basal ganglia.
And this table just lays it out perfectly. Look, for CMV, you're thinking periventricular calcs. And remember, it's also highly associated with polymicrogyra. For Toxo, you're looking for those basal ganglia or just kind of random calcifications, and you'll often see massive hydranencephalus with it. Then you've got rubella. You don't see it as much anymore, but its calling card isn't really calcification. It's a vasculopathy. So what you'll see is high T2 signal out in the white matter from all that ischemic damage.
Okay, listen up, because this is a really crucial point about neonatal herpes. This is almost always HSV2, and you need to take everything you learned about adult HSV1 and just throw it out the window. Seriously. In adults, it hits the temporal lobes, the limbic system, but in a newborn, the virus goes after the endothelial cells in the blood vessels. This leads to thrombosis, and you get these absolutely devastating hemorrhagic infarcts. We're talking widespread brain destruction, encephalomalacia. It is a totally different disease.
All right, let's switch gears and build on this. We're moving to our next major pattern, white matter changes. And we're going to look at this specifically in the setting of an immunosuppressed patient, someone with AIDS. I want you to tattoo this phrase on your brain. The U fibers are the key. I mean it. These little short association fibers, right under the cortex, they are the absolute critical landmark that's going to help you solve one of the biggest diagnostic headaches in this patient group.
So let's put these two side by side. On one side, you have HIV encephalitis. What do you see? You see this symmetric, high T2/flare signal deep in the white matter. But, and this is the whole game, it spares the subcortical U fibers. Okay? Now look at PML. Progressive multifocal leukoencephalopathy. It's asymmetric, and, you guessed it, it involves the U fibers. Another big clue? PML is going to be dark on T1, where HIV encephalitis is usually T1 normal. But I'm telling you, that U fiber involvement, that's your moneymaker right there. That's the highest yield differentiator.
Okay, pattern number 3. Let's play what I call the enhancement game. How something lights up with contrast and where it lights up can tell you so much. This is how we're going to solve some of those classic diagnostic puzzles, and we'll start with meningitis. Just like with calcifications, not all meningeal enhancement is the same. In your standard bacterial meningitis, what you see is leptomeningeal enhancement. The contrast just fills up the sulci, basically outlining the surface of the brain. But TB meningitis plays by different rules. It has this classic love for the basal cisterns. So when you see this thick, lumpy, nodular enhancement down at the base of the brain, especially if there's hydranencephalus, man, you've got to be thinking TB. It has to be at the very top of your list.
And now, for the final boss of neuroradiology puzzles, the ring-enhancing lesion. You know what it is, right? It's just a wall of contrast around a center that doesn't light up. But here's the secret, the thing that will save you time and time again. Not all rings are created equal. The way the ring looks, its morphology, that's your first and probably your most important clue.
This really shows the core difference. Take a look.
On the left, you've got the abscess. See how smooth and well-defined that ring is? It's like a perfectly built, thin wall. Now look at the tumor on the right. It's the total opposite. The ring is thick, it's irregular, it's shaggy. That simple difference in the wall is huge. Smooth and thin should make you think infection. Thick and irregular, you've got to be thinking malignancy.
Okay, but what if it's not so clean? What if the ring is kind of in between, ambiguous? The morphology just isn't classic. Well, this is when you stop looking at just the anatomy and you start looking at physiology. It's time to bring in the big guns, our tiebreakers, the advanced imaging sequences. And this, right here, is the slam dunk. First, look at diffusion-weighted imaging, or DWI. A bacterial abscess is basically a bag of pus, right? And pus is thick and gooey, it's viscous. It severely restricts how water molecules can move. So what does that mean? It means it's going to be screaming bright on DWI. And the necrotic tumor, on the other hand, is usually just watery fluid in the middle, so it doesn't restrict. Next, you look at MR spectroscopy. An abscess is full of anaerobic bacteria, and they produce a ton of lactate. You'll see this huge lactate peak. A tumor? It's all about high cell turnover, so you see a massive choline peak. I'm telling you, you put these two sequences together, it's just incredibly powerful.
All right, let's wrap this up and put it all together. We've gone through the key patterns. Now we're going to boil it all down into one single, powerful playbook that you can actually use the next time you're on call.
This is it. This is your on-call cheat sheet. Let's just run through it rapid fire. You see periventricular calx, you think CMV. You see basal ganglia calx and hydranencephaly, you think Toxo. Asymmetric white matter that involves the U fibers, that's got to be PML. Symmetric white matter that spares the U fibers, HIV encephalitis. See that thick enhancement in the basal cisterns? Think TB meningitis. And the big showdown. A smooth ring, bright on DWI with a lactate peak, that's an abscess. An irregular ring, no restriction, and a choline peak, that's a tumor. Got it?
So there you have it. That's the playbook. Now, the next time that scan pops up at 3 in the morning and you see that ring-enhancing lesion, what are the first two sequences you are going to look at to absolutely 100% nail the diagnosis? Yeah, you know the answer. You've got this. Great job today, everyone.